Okay, in this lecture, we are going to briefly look at the amount of tension that can develop in cardiac muscle and how we might change that and why we might want to change that. Before we take a look at that big overarching question, I briefly want to talk about skeletal muscles because we've learned about some of this in prior lectures. So I think it's probably pretty intuitive why you might want to grade or vary the amount of tension in a skeletal muscle. If you're lifting something really lightweight, then you probably don't need very much tension. If you're lifting something really heavy, then you need a lot more tension. And I think that probably makes intuitive sense to most people why there would be value in changing the amount of tension in your skeletal muscles. And we also learned that there are kind of three things that influence the amount of tension. One of which is really the starting sarcomere length. So starting sarcomere length in skeletal muscle is largely a function of the joint angle when you start that contraction. So if I have my bicep right here, my optimal starting length is like this. If I hyperextend my elbow, then the starting sarcomere length is too long. And if I hyperflex, then the starting sarcomere length is too short. And if I have those kind of extreme ends, hyperextended, hyperflexed, then I might get like a 20% drop in my tension. But notice that's really passive. It's just kind of a consequence of the starting joint angle. It's not something that you can change with your central nervous system. Whereas the central nervous system absolutely can impact the amount of tension that is generated in the skeletal muscle through two different avenues. One of which is to summate individual twitches, and the other of which is to recruit more motor units. Okay, so we're going to come back and take a look at how the cardiac muscle can adjust the tension. But first, we need to spend a little bit of time talking about why it might be important for the cardiac muscle to adjust the amount of tension. So in order to do that, we need to basically go back to what is the heart's purpose? The heart's purpose is to move blood. And I want to give you an analogy here. I'm going to draw out a tube of toothpaste. And you know how like sometimes when you leave your toothpaste tube uncapped and there's like a bunch of gross like toothpaste kind of sitting here and it can almost form like a hardened glob that kind of creates a seal. So if I want to get toothpaste that is in here out, I'm going to have to squeeze harder if that glob is there than if the glob isn't there. In other words, I'm going to have to put more tension when I squeeze my toothpaste tube if the glob is there because I have to overcome the amount of pressure that this glob is exerting on that hole. I have to put more pressure in the actual toothpaste here so that it's able to pop off that little glob, and then of course my toothpaste will come shooting out. So what's the relevance of that basic analogy that you're all going, yes, I totally see that. What does that mean? So when we think of our heart's ability to move blood, there's a couple different things going on. First of all, there's already a lot of blood in the vascular system, in the blood vessels, and that has pressure. And fluid always moves down its pressure gradient. So if I have my heart, I'm just going to draw a real kind of basic heart here. And then here's my vessels, again, extremely basic. If the pressure, let's say blood is being pushed this way, if the pressure here is 100 millimeters per mercury, and you may not know what that means yet, but that's okay, we'll get to that. If the pressure is 100 millimeters of mercury, then that means that if I have new blood in this heart that I want to push here, I need to overcome this pressure. So I need to put at least 100 millimeters of mercury of pressure into this new blood in order to force it into that vessel and move all of this blood all the way around. Okay, so how do I do that? With a contraction. Just like I squeeze my toothpaste tube, the heart is squeezing the blood. So now let's quickly revisit the heart anatomy, because not all chambers are created equally. When we learned about heart anatomy, we know that we have 2 atria and 2 ventricles. The ventricles are the workhorse of the heart. They are the ones that provide that squeeze to get the blood out into the arteries and into the system. But between the right ventricle and left ventricle, which one do you think has to work harder? The left ventricle. Why? Because the left ventricle has to provide enough force to get the blood not only out into the aorta, but all the way down to the toes, all the way up to the head, and then back again. That's actually quite a lot of force. Whereas the right side of the heart, the right ventricle, pushes blood into the pulmonary circuit, but the pulmonary circuit is the lungs. The heart is here, the lungs are here. This is not a far distance that you have to travel. So it's just like, back again. Okay, pretty easy. So and I don't want to diminish the importance of the right ventricle, but when we think about the amount of work that needs to be done, the left ventricle has to generate a lot more tension than the right ventricle does. So we tend to focus on the left ventricle a little bit more than we focus on the right ventricle, because when we think about the overall functioning of the heart, it's really the most important chamber. So let's come back to this idea of the left ventricle now. And, we're squeezing this left ventricle and we're trying to move blood. What are some things that might influence how hard I need to squeeze? And so one thing that I talked about was this idea of the toothpaste tube where there's some sort of resistance, in this case like a glob, a hardened glob at the top. So if there's a lot of resistance or already pressure in your vascular system, like let's say you have super high blood pressure, instead of 100 millimeters of mercury here, let's put 200 millimeters of mercury here. If you have really high blood pressure, for instance, then guess what? You're going to have to overcome 200 millimeters of mercury of blood pressure rather than 100. That means that the amount of tension that left ventricle is going to need to generate is going to need to be a lot greater to push the blood out. So hopefully it makes sense then that blood pressure itself is going to be a factor. When you have really high blood pressure, your left ventricle is going to have to generate more tension to overcome the blood pressure in your vascular system. Another example is how much blood do you want to move? So let's come back to my toothpaste analogy and assume that I actually don't have any blockage there. If I want to get a whole lot of toothpaste out in one squirt, right, like a huge amount, then it would make sense that I would basically take my toothpaste tube and 1, 2, 3, really squeeze it hard so that the toothpaste comes shooting out. But if I only want a little bit of toothpaste, I'll just barely squeeze it at all. So the amount of blood that's in your ventricle at the start of your ventricle contraction is going to be important. If I need to move a lot of blood, I need to squeeze harder. If I only need to move a little bit of blood, I don't need to squeeze that much at all. So these are some factors that we have to think about or consider when we think about LV. LV stands for left ventricle here, in terms of how much tension the left ventricle wants to generate. So essentially, the greater the resistance or blood pressure in the vascular system, the more tension my left ventricle is going to need to generate during its contraction. And the more blood I want to move, the more tension that left ventricle is going to need to generate. So I'm actually going to focus for a moment on this one. The volume of blood to eject, because there's a name for that. It is called stroke volume. Stroke volume is the actual volume of blood ejected from the left ventricle during ventricular contraction. Now you can have a stroke volume for the right ventricle also, but again, for reasons that I already said, we tend to focus on the left ventricle. Okay, so what is going to determine stroke volume? Well, one thing that is going to determine stroke volume is how much blood you have in the ventricle at the start of your contraction. So where's that blood coming from? So you've got your left ventricle and blood's coming in from the left atrium, right? So a lot of it's leaking down and then the atrium contracts and kind of pushes the last 5-10% of it down. So what kind of volume are we talking about? Well, at rest, it might be like 130 milliliters. Now, what is 130 milliliters? I don't know, maybe about this much if you're looking at a can of soda. So that's the amount in the left ventricle, right? And when the ventricle contracts, actually only about half of it usually leaves. And so the stroke volume is on an at rest for like an adult male would be around 70 milliliters, about half. And then the other half stays in there. And then additional blood comes in, and then you push it out, and additional blood comes in, you push half of it out, and additional blood comes in, etc. So you never squeeze every last drop out during every contraction. But if I generate more force, I'll push out more blood. So why might I want to do that? Well, let's say that I'm starting to exercise. If I start exercising, then it turns out that my ventricle will fill up with a lot more than 135 milliliters of blood. I might get 200 milliliters of blood. And if I'm only pushing 70 mils out, that's not good. I need to push more out, right? So if I increase the amount of volume in my heart to start with, then that is automatically going to trigger a stronger contraction. And there's no central nervous system modulation at all. This is actually kind of a deviation of the starting sarcomere length. So this is really kind of an interesting phenomenon. In fact, it's so interesting that it's called the Frank-Starling Law. It gets its own name. So the starting sarcomere length for cardiac muscle absolutely influences, and by a very large margin, how much tension is generated. If I don't have very much fluid in my ventricles, I don't need to generate very much force, right? So guess what? My sarcomeres don't get very stretched because the walls of the myocardium are kind of stretchy. So the more volume that I put in here, it's like a water balloon, the more stretched out they become. So if I don't have very much volume, then my walls don't get very stretched, and you know what? I don't generate very much force at all because my sarcomeres kind of start out too short. But as more fluid fills up my ventricles get stretchy and the sarcomeres stretch out, and that automatically generates more force. So let me give you a quick analogy here. This is elastic. So you can almost think of these sarcomeres like elastic. In fact, there is some elastic involved here. But if I take this piece of elastic and I only stretch it out a little bit and then let it go, not a whole lot, right? Not a whole lot of snapback, not a lot of force. Only stretching it out a little bit. But if I take the same volume and I stretch it out a lot more, I get a lot more snapback. So by stretching out the sarcomeres more, because you are filling up the ventricle with more blood, it will automatically result in a stronger twitch. And therefore, you will generate more pressure to push more of that blood out, which is really an ingenious design. So it's not a term I will use on the test, but it is a concept that you need to understand. So if you're at rest or sleeping and your left ventricle doesn't fill with very much blood, then your starting sarcomeres are going to not be very stretched, and therefore you're not going to generate very much tension. But for instance, during exercise, when the amount of blood that's coming into your ventricle increases, then you're going to start stretching out your sarcomeres more. And it's going to result in more tension, which is going to push more blood out. So the starting sarcomere length actually has a really big impact on the amount of tension that is generated during a twitch, and therefore the amount of blood that is ejected from the left ventricle. So let's go ahead and write that out. In skeletal muscles, we saw that starting sarcomere length matters. It matters a lot more in cardiac muscle. All right, pause the video if needed to write this down. And then I want to come back to this image here. When we did skeletal muscle physiology, we actually looked at 3 different scenarios. We had optimum. The optimum starting length of the sarcomere is going to be where every myosin head is capable of finding an actin binding spot, but there's still room to shorten. We looked at what happened when it was too short, but then we also looked at what happened when the sarcomeres became too long, too stretched. Notice that too long or too stretched is not an option here. So does that ever happen in real life? And the answer is yes, and it's really problematic. So in a homeostatically functioning heart, the default position is actually the sarcomeres are too short. And this is what happens when you're at rest. But as blood fills up beyond an at-rest amount or for other reasons, then the sarcomeres start to stretch and then they'll generate more force to try to move that additional blood out of your left ventricle. Let's assume for a moment that you have a leaky semilunar valve, an aortic valve that is leaky. So what is a leaky semilunar valve? The aortic valve separates the ventricles from the aorta. It kind of looks like this, has a leaflet design to it. And when you put pressure underneath here from the heart, it pushes open the valves and then blood shoots through and then catches. And the whole idea is that the valves need to shut to prevent the blood that's now in the aorta from falling back into the ventricle. But there are diseases out there called aortic stenosis, where the aorta leaflets get degraded and leaky. So it's a leaky seal. It's no longer a nice complete seal. And when that happens, blood continues to fall back into the ventricle. So you push blood out and some of it moves forward and some of it comes back. So the volume of blood in your ventricle is always greater than what it should be because you always get backwash. And as a consequence, your heart is consistently stretched. Well, one of the things that your heart will do, your heart is a muscle, and it's capable of hypertrophy. And so when it feels the need that it's not able to move blood efficiently, it will compensate by hypertrophying. The problem with that is that if you get too much hypertrophy, your sarcomeres start to stretch even more because your entire muscle, your heart muscle, elongates. And if they stretch too much, then you end up with another problem. You end up with that issue where when you start to try to contract, there aren't very many cross bridges that can be made. So now you have a really stretched out heart filled with blood, and you can barely muster any strength at all because your sarcomeres are too stretched. If we go back to the elastic analogy, the analogy here is going to be like elastic from really old gym shorts that is stretched out and doesn't recoil. So when you let go, there's no recoil. It's just completely stretched out elastic. So in the same way, the heart will fail to generate enough tension because of stretched out sarcomeres, and that is called congestive heart failure. So congestive heart failure is a downward slope that will eventually culminate in death if something else doesn't kill the person first. But once you start down that slope, it's really difficult to flatten out the curve. You keep kind of getting worse, and worse. So congestive heart failure is something you want to avoid. So when somebody has extreme hypertrophy in their heart, it's very much kind of not like skeletal muscles, not a good thing. Anyway, so is it possible for the sarcomeres to stretch out beyond what you see here? Yes, but it's not within the healthy homeostatic range. You're looking now at a diseased state, usually because of some failure somewhere else. It could be with a heart valve. It could be something else where you weren't moving blood effectively, and so your heart hypertrophied to try to compensate for that. And once it hypertrophied too much, the sarcomeres stretched out too much. So that's a little foray into congestive heart failure. So now that we've thoroughly investigated the starting sarcomere length as it applies to a cardiac muscle, let's briefly talk about what the central nervous system can adjust in cardiac cells. So the central nervous system can also play a role in adjusting the amount of tension and therefore trying to, for instance, help increase the stroke volume, the amount of blood that's ejected from the left ventricle. But it does not do it by summating twitches, and it does not recruit more motor units. So the two things that you see for skeletal muscle do not apply to cardiac muscle. Here's why. In cardiac muscle, we already learned that we cannot be summating twitches. First of all, the absolute refractory period of the action potential prevents it. But it's also a good thing. We do not want to summate twitches. In order to move blood effectively, we have to have a twitch, contraction, and then a relaxation where blood fills back in. If we don't relax that twitch, very little blood will come in, and then you won't have anything behind it to push again. So you've got to let it relax so that it can fill back with blood. So we do not summate twitches in cardiac muscle. Doing so would be counterproductive. In addition, all of the myocardial cells are connected by gap junctions. And since electrical signals flow over and through all those gap junctions, every single contractile myocardial cell participates in every heartbeat. It's not like some of them sit out and go, well, I'm just not going to be a part of this. I'll wait until the central nervous system says that I should do it. That's not a thing in the cardiac system. They all participate in every heartbeat. So, unlike skeletal muscles, there are no such thing as motor units, and therefore there is no recruiting motor units. So what can the central nervous system do to adjust for the tension? And the sympathetic nervous system, which is part of the autonomic nervous system, can actually grade individual cardiac twitches. So this is another difference between skeletal muscle and cardiac muscle. In skeletal muscle, twitches are all or nothing. They run the same way every time. You take one skeletal muscle fiber and it twitches, it's going to be the same tension and the same amount of time every time. In cardiac muscle, twitches can be graded. The sympathetic nervous system has the ability to make twitches stronger and shorter. And how this works will actually be discussed in a later lecture. But let's go ahead and put that down now, and we'll introduce it. So there is a default twitch. But under the sympathetic nervous system, the twitch looks something like this. It is stronger and it is shorter in duration. So by increasing the strength of the twitch and shortening the amount of time of this twitch, you basically transition from something like this is default, to something like this. And what it does is it allows you to increase the stroke volume. So again, this will be discussed in more detail in later lectures. All right, we've actually covered quite a bit here in terms of how we can adjust the tension in cardiac muscle, and then why adjusting the tension in cardiac muscle is important. I'll see you for the next lecture, where we start looking at pacemaker cells and how those work.